SWAYAM Prabha. Digital India. Educated India.
Good morning, ladies and gentlemen. Today for 30 minutes or so we will talk about the brain tumors, so called the tumor of the central nervous system. Just to remember a simple classification of the brain tumors, they are better classified as the tumors of the brain, which are the primary tumor of the brain, tumors to the brain, which are the metastases to the brain, and tumor around the brain. The reason why I am telling this is brain is one of the few organs like lung, bone, liver, where the metastases are more common as compared to the primary tumor. So when we are dealing with the brain tumors, one should remember these facts, that it can be metastasis rather than the primary tumor of the brain. Brain is well protected by the bony case, and this is very thin, which separates the soft tissue around the scalp from the brain. Though any tumor which occurs in the either in the bone or in the soft tissue can infiltrate into the brain. For example, there are a lot of tumors which are in the skull base, paragangliomas, chordomas, chondromas, chondrosarcoma, some of the salivary gland tumor and soft tissue sarcoma. Any of the tumor can grow inside and appear as if it is tumor of the brain. Therefore, one should be very cautious while interpreting the tumor of the brain. One should really think of, is it really tumor of the brain, or is there any other soft tissue or any other bony tumor which is infiltrating into the brain. Now, the tumor of the central nervous system, which comprises about the brain and spinal cord. So, the primary tumor, or there may be metastasis at both these places. The metastases in the spinal cord are less common as compared to the metastases in the brain. Before going to the individual tumors, there are certain facts about the brain tumors which one has to remember. The most common tumor in the brain are the metastases, followed by gliomas, meningiomas, pituitary adenomas, and nerve sheath tumors. The another fact is that in adults, the most common tumor is astrocytoma, and they are mostly high grade, what we call as the GVM grade 4 tumors. About 75% of the tumor in the brain in adults, they occur in the supratentorial locations. This is in sharp contrast to the childhood tumors, where 75% are infratentorial or so called in the posterior fossa. The most common tumor in children are the Medulloblastoma, Pilocytic Astrocytomas, and ependymomas. Now, one of the problems with the diagnosis of the brain tumor is the symptoms are routine. They are similar in almost all the cases. The most common symptom is the raised intracranial pressure, which can manifest as a headache or the visual problems or vomiting, and depending upon the locations, patient may present with seizures, neurological deficits or cognitive declines, growth failures, and rarely there may be some manifestation in the periphery. For example, there may be cutaneous nevi and the patient may be having melanoma of the brain. Now, what samples usually we get for the diagnosis? Now, this is well known fact that now we are moving from the larger biopsies to the smaller biopsies, and one of the is the CSF examination, which is easy to get. There are very few tumors which can disseminate through the CSF and can be diagnosed. The other is the biopsies. Now, stereotactic biopsies, they are the small biopsies, easy to do, and they are usually done for the deep-seated tumor. Then there are endoscopic biopsies, And lastly, there may be the open surgery, what you would call the craniotomy, where you get the different types of excisions, which may be complete, subtotal, or partial excision. These are some of the examples where one can see the stereotactic biopsy needle. This is the endoscopic, this is the open surgery biopsy. Now WHO after every 10 years is revising the classification of the tumor. The reason is that one should use the uniform nomenclature throughout the world for the diagnosis and for the treatment. What we need in the lab for the diagnosis of brain tumor? We need the clinical data, and one of these age and sex site, they are very important for the diagnosis of the brain tumors. Then the radiology, what are the radiological finding, and finally the interpretation of the biopsy. What we have to do is the accurate diagnosis to grade the tumor, which is very important from the therapeutic point of view to predict the prognosis and response to treatment. And for these things, nowadays the more and more stress is laid on the molecular genetic alterations, which better predict the response to treatment and prognosis. Now, based on our grading, the treatment is decided. For example, in the grade 1 tumor, which are localized tumor, they can be easily done by surgery. Grade 2 tumor, which are a little bit infiltrative, and surgery plus radiotherapy may be indicated. And for the higher grade tumor, surgery, radiotherapy and chemotherapy combination works better. Now, as we know that any structure which is inside the cranium, brain tumor can arise from all those structures, and the most common are the neuroepithelial tissues, which comprises the astrocytic neuronal cells, the nerves, meninges, pineal region. There is no lymphatic drainage or the lymphoid tissue in the brain, but somehow some of the lymphomas can also arise from the brain. One has to remember that some of the leukemia, the brain is the site where recurrences are common. There can be some germ cell tumors, there can be tumor from the pituitary glands, metastasis, and some other tumors. Now, coming to the meningioma, they are the common tumors. They most commonly occur in the middle or elderly people, mostly in the convexities, arises from the arachnoidal cells, and the rare sites are in the spinal cord. They are very slow growing tumor, and the prognosis is good, but they are recurrences, and for the prediction of the recurrences, it is important to grade these tumors. They are grade 1, grade 2 and grade 3 tumors. There are two criteria for the grading. One is some cellular criteria, mitosis, necrosis, invasion of the brains, but there are some other criteria which are morphological. For example, the clear cell change in the meningioma, chordioid morphology, they are also grade 2 tumor. Some of the papillary tumor, rhabdoid tumors or rhabdoid meningiomas, they are grade 3 tumors. So, grading is not only depend upon the cellularity and the mitosis and some other histological features, but also based on the morphology. And this grading is important because as we go from the grade 1 to grade 3 tumor, the chances of recurrence increases. Now, one is the morphology, as I mentioned, the number of mitosis, there are some cutoff given by the WHO. For the grade 1 tumor, it is less than 4, for grade 2 it is 4 to 20, and for grade 3 tumors, the mitosis rate should be more than 20 per 10 high power field. So, these are some of the features. Invasion of the brain, even if it is morphologically it may be grade 1 tumors, but if there is an invasion of the brain, it will behave like a grade 2 tumor. So, therefore, now in the recent WHO classification of the brain tumor, it is assigned grade 2. So, brain invasion is very important factor for the diagnosis. These are some of the examples of the grade 1, grade 2 and grade 3 tumor. For example, this is a grade 2 tumor. This is a chordoid morphology. It resembles like chordomas morphologically. There may not be very high mitosis or the MIB labeling index, but actually it behaves like grade 2 tumors. Clear cell morphology, for example here, clear cell meningioma, they are grade 2 tumors. Morphologically they may look like grade 1, but behavior wise they are grade 2 tumors. So the morphology is also very important for the diagnosis of the meningioma. Now the second most common tumor is the schwannomas. They are grade 1 tumor, they are benign tumor. They are most commonly seen at the CP angles, but can involve the other nerves also. They are very slow growing. They are some of the examples of the schwannomas. Actually bilateral schwannomas at both the CP angles are more common in the neurofibromatosis type 2. Now based on the morphology, depending upon the cellularity, one is the Antony A areas and the other are the Antony B areas. Antony A areas are more compact spindle cells, where the Antony B areas are more loose and they may be rich in foamy macrophages. One may get the verrucous bodies. And as far as the immunohistochemistry is concerned, these cells are immunopositive for S100 proteins. Schwannomas are also positive for GFAP. Neurofibromas are less common in the brain. They are more common in the peripheral nerves, maybe in the skin. They are more infiltrative, and any mitosis in the neurofibroma actually indicates that it is transforming into a neurofibrosarcoma. The presence of mitosis is very, very important in the neurofibroma as compared to the schwannomas, where mitosis is not that important, but the morphology is more important. Now coming to the largest group of tumor, neuroepithelial tumors, which may be glial tumors, which may be the neuronal tumor, which may be mixed glial and neuronal, from pineal gland tumors and embryonal tumors. Now, of all the gliomas, astrocytomas are the most common, followed by the oligodendrogliomas and ependymoma, which almost not more than 10 to 15% of all the glial tumor. Therefore, many times clinicians do use the term gliomas, which is actually synonymous for them for the astrocytomas. Now, in the latest WHO classification, the gliomas are classified into the diffuse glioma, which may be astrocytomas as well as the oligodendroglioma. The very important point in the recent WHO classification is they have given a lot of importance to some of the biomarkers. For example, IDH1, IDH2, ATRX, P53, EGF amplification. And based on these, whether it is IDH mutator or wild type, the prognosis depends. Now coming to the classification of the astrocytic tumor, if you see all the astrocytic tumor or the ependymomas, grade 1 tumors are by name. They have a very characteristic morphology, whereas the grade 2 to grade 4 tumors we have taken into consideration for the grading. One is cellularity of the tumor. We compare the cellularity with the brain parenchyma, non-normal surrounding brain parenchyma, if it is included, pleomorphism of the cellular pleomorphism, nuclear pleomorphism, anaplasia, mitosis, necrosis, and endothelial proliferation. If there is no mitosis, only increase in cellularity, it is grade 2 tumor. If there is a mitosis, it is grade 3 tumor. If either there is a necrosis or endothelial proliferation, they are grade 4 tumors. So necrosis, which is actually described as the palisading necrosis, that means there is a central area of necrosis and they surrounded by these neoplastic cells in a palisading manner. Or there may be only or along with the necrosis endothelial proliferation. Grade 1 tumors, most common are the pilocytic astrocytomas, which occur in the children, younger age, and they are mostly the midline in location. Most common in the posterior fossa, in the cerebellum, then maybe in the hypothalamus, supracellular region, or rarely in the cerebral hemisphere. They are localized tumor, well circumscribed as compared to the grade 3 tumor. Therefore, you do surgery, remove the tumor, and the prognosis is good. Chemotherapy, radiotherapy are usually not indicated. These are some of the examples of pilocytic astrocytoma. One of the very characteristic feature of these pilocytic astrocytoma, they have cyst. This is the cyst radiologically, and a small mural nodule. So, cyst with the mural nodule is very characteristic of some tumor, and one of them is the pilocytic astrocytoma. These are some of the gross pictures in the autopsy, where this is a cerebellum, this is a large cyst, and there is mural nodule. They have very characteristic morphology. They have two types of area usually, the loose areas and compact area, which are spindle cells. And they have a lot of these eosinophilic structure, which we call as the rosenthal fibers. They are very characteristic of pilocytic astrocytoma. These cells are immunopositive for GFAP. Mitosis are usually absent, but there may be what you call as the glomerular proliferation of the blood vessels or microvascular proliferation. So, there very sometime pathologically one may think of whether they are the glioblastoma multiforme, which are grade 4 tumors. So, one should look for the mitosis in those instances to differentiate between the pilocytic from the grade 4 tumor. These are the some of the examples so called classically described the pennies on the plates. These are the multinucleated cells, and the MIB is very low. The cells are immunopositive for GFAP. Now, one of the very important the molecular change which has been found in the pilocytic astrocytoma, either there is a mutation in the VRAF V60 600, or there may be some fusion which is described as the ER119 and the VRAF gene. So, these two genes which are normally far away, somehow they come very close to each other and form a fusion proteins, which may lead to the activation of some of the molecular pathways. The importance of this finding is there are 2 points. One is the diagnostic. Sometime when there is a difficulty in the diagnosis, one can study these markers, maybe by FISH or maybe by other methodology, or sometime when surgery is not possible. Now, people are looking for more and more of these targeted therapies. So, there may be some drugs, for example, one drug which acts in the, which is very effective in the melanomas, which is a VRAF inhibitors, is also effective in the pilocytic astrocytoma. Just to mention another tumor here, because it resembles the mural with cystoma like the pilocytic astrocytoma, very close differential diagnosis radiologically. Also in the cerebellum, this is the meningioma, but these are tumors where there are a lot of blood vessels, they are stromal cells, and they are not glial tumor. The another tumor is the ganglioglioma. There is another tumor where one can get the cyst with mural nodules. Most of the time they present with the epilepsy, intractable epilepsy. They also show the mutation of the VRAF V600E mutations, which may help in the diagnosis as well as for the targeted therapy. These are some of the microscopic pictures which show a lot of these dysplastic neurons. Now, dysplastic neuron has to differentiate from the normal neurons in the histology. These dysplastic neurons, they are binucleated, they have more eosinophilic cytoplasm as compared to the normal neuron, which are more of nissal substance, and these are some of the features. They are more reticulin rich, MIB is very low, and this tumor usually associated with the epilepsy. The another low grade tumor is the subependymal giant cell astrocytoma, so called the SEGA. This is also grade 1 tumor, mostly located in the lateral ventricle, rare in the third ventricle, and usually associated with the tuberous sclerosis, maybe tuberous sclerosis 1 or tuberous sclerosis 2, common in children and young adults, and as they occur in the near the foramen of Monro. So, the most common presentation is the hydrocephalus and raised intracranial pressure. Radiology is very characteristic. The histologically they may look like very bizarre looking large cell, giant cell. They have some spindle cell eosinophilic so-called the gematocytic cells, and there is a very characteristic, either there is a lymphocytic sprinkling or there may be some mast cells amidst these tumor cells. These tumors may show the loss of tuberin or hamartin, then they are associated with the tuberous sclerosis. Now surgically sometimes it is difficult to do complete excision because of the larger size, but otherwise they are grade 1 tumors and surgery is the treatment of choice. As we know that the mTOR pathway is involved in the pathogenesis of this tumor, so in those tumors which are not amenable to surgery, one can give the mTOR pathway inhibitors which reduces the size of the tumor and they can be excised later on. The prognosis is excellent. Now coming to the grade 2 tumors, so called the diffuse astrocytoma, they occur mostly in the adults, very rare in children. The most common sites are the cerebral hemisphere, may occur in the brain stems, spinal cord, and one of the features of these grade 2 tumor is that they may progress from the low grade to higher grade. For example, this tumor may be grade 2 and after 5 years when it recurs, it may recur as grade 2 or it may recur as grade 3 tumor. So these tumors progress from low grade to high grade tumor. These are some of the examples of these diffuse astrocytoma. They show grease cellularity, this microcystic change, but there is no mitosis and MIB labeling index is very low. As I mentioned in the latest WHO classification, lot of stress was given to the IDH1 mutations which can be detected by this antibody which is against the mutated protein, and whether the IDH positive or negative, the prognosis depends upon the IDH positivity. Anaplastic astrocytoma, they are just like the grade 2 tumor, but the cellularity is more and there is mitosis. The number of mitosis, what is the cutoff to call it as a grade 3 tumor, is not defined by WHO, but any number in the increase in the mitosis, the diagnosis favor the anaplastic astrocytoma. It is very important to differentiate from the grade 2 tumor because these tumors may need chemotherapy as compared to the or radiotherapy as compared to grade 2 tumors. These are some of the examples. There are pleomorphism, increased cellularity, and these are the mitosis, and the MIB labeling index is very high. But one has to remember that there is no necrosis or endothelial proliferation in these tumors. Once you get these necrosis and endothelial proliferation, actually diagnosis is the grade 4 tumor. The glioblastoma multiforme or the grade 4 tumor, which are the most common tumor in adults. The most common site are cerebral hemisphere and rarely they can occur in the cerebellum and very rare in the spinal cord. Prognosis is very bad. The survival is less than 1 year if there is no treatment, and with the surgery, radiotherapy and chemotherapy, the survival has not improved much. As the name indicates, glioblastoma multiforme, it has this very variegated appearance, large areas of necrosis, hemorrhage. This is the ring enhancing lesion with the very significant edema of the brain. And the most characteristic diagnostic point is the necrosis, what is we call as the palisading cells around this necrosis and or endothelial proliferation. Now the glioblastoma multiforme, they are classified into the subgroup into two categories. One are the primary GBM, what we call the IDH wild type glioblastoma. Majority of the tumor in adults, more than 90%, are primary GBM. They don't show the IDH mutations, but they may show the EGFR amplification. They are negative for p53 mutation. They occur in the older age and prognosis is very bad. As compared to the IDH mutated tumor or the secondary GBM, which occurs in the younger age, they progress from the lower grade, either grade 2 or grade 3. They are negative for EGFR, may show the p53 mutation, and they are immunopositive or show mutations for IDH1 or IDH2 gene. Prognosis is comparatively better than the primary or wild type IDH. This is one example of the primary GBM. This is a necrosis. This shows the immunohistochemistry for EGFR, which is positive, and this is a fish showing the EGFR amplification. This is the endothelial proliferation and MIB labeling index is high. This is the secondary GBM, where a lot of giant cells, but P53 is positive and the EGFR is negative, and these tumors are usually positive for IDH1 or IDH2. Now, oligodendroglioma are the second most common glial tumors. They occur in the young adults, mostly in the cerebral hemispheres, and the prognosis is good as compared to the astrocytic tumor. Now, two defining criteria now for the oligodendrogliomas are the IDH1 or 2 mutations, or they show the co-deletion of 1p19q. These are the two very important defining criteria for the diagnosis of the oligodendrogliomas. This shows the infiltrative tumor, contrast enhancing in the cerebral hemisphere. They are very characteristic morphology. Under the low magnification, one can see that these are the clear cells, the cells with clear cytoplasm with central nucleus, what we call as the fried egg appearance. In the surrounding brain, one may find a lot of these neuronal setalloses, what we call as the central neuron, surrounded by a lot of these oligodendroglial cells. This is another example, and depending upon the number of mitosis and endothelial proliferation, they are graded into grade 2 and grade 3. Just to mention here that there is no grade 1 oligodendrogliomas as compared to the astrocytoma or the ependymomas. And where the number of mitosis is more than 6 per 10 high power field, or there is endothelial proliferation, this is graded as grade 3 tumors. Now, this fish can be, this 1p19q can be studied by fish, by RT-PCR or by other methodology, and the IDH1, the antibody is available. One can study this mutation by this antibody, or one can do the sequencing. Now, this is very important that 1p19q co-deleted tumor, whether they are grade 2 or grade 3, they show they are radio sensitive or chemosensitive. The prognosis of these co-deleted tumor is excellent. Now, there is one category, mixed gliomas, what we call oligoastrocytoma. In the latest WHO classification 2016, this entity is placed under the questionable category. Many authors think that there is no mixed category, either they are oligodendrogliomas or they are the astrocytomas based on their molecular studies. Now, the third most common tumor in the glial category is the ependymomas. They are graded grade 1 to grade 3. The grade 1 are by name, as I mentioned earlier also. They are localized, so called the subependymoma, myxopapillary ependymoma, and the grade 2 tumors, they are classical. They may show the classical histology, or they may be variants, papillary, clear cell, tenocytic. WHO has introduced another categories, RELA fusion ependymoma, which may be grade 2 or grade 3, and the anaplastic ependymoma. Now, recently it has been proposed by the molecular studies that there are 9 subgroups of ependymoma, 3 each in the supratentorial compartment, posterior compartment, posterior fossa, and the spinal cord. In each compartment there is a subependymoma which has a good prognosis. In the spinal cord there is a myxopapillary ependymoma which has a good prognosis. But in the supratentorial and posterior fossa, what is represented by these red dots, they are the one which are very bad. They may be grade 2 or maybe grade 3, but these are the one which shows very characteristic molecular alteration. I will come to those alteration later on. It has been shown that there is one fusion of these genes, C11ORF95 RELA. What happened during the chromosynthesis, there is a random shaking of the chromosome. So, these two genes, they come together, and the function of this C11ORF is not known, but RELA, which is involved in the NF-kappa pathway, which leads to the activation of NF-kappa pathway, and these ependymoma which show this fusion, they have very bad prognosis. They usually occur in the supratentorial location, and the prognosis is bad. These two figures shows the prognosis of the RELA fusion and RELA positive and negative cases. The another importance of this diagnosing of this entity is that many of these tumors, they don't respond to the usual chemotherapy or radiotherapy. So now there is need to search for another markers, maybe some targeted markers for the treatment of these tumor. So one should not expose these young children unnecessarily to some of the chemotherapeutic agents which are given for the other ependymoma. In the posterior fossa, there are two groups, one is group A, one is group B, and one group A which occurs in the younger age as compared to the group B which occur in the older age. The group A tumors are mostly laterally located, they are more invasive, and there are more chances of recurrence and metastasis, and they show the very characteristic 1Q gain which can be detected by FISH as compared to the group B tumor which are more medium, occur in the older age, and they don't show 1Q gain. Now histologically it is very difficult to differentiate group A from the group B tumors. They may be grade 2 tumor, they may be grade 3 tumor, but group A tumor they have a very bad or dismal prognosis, so it is very important to do the 1Q gain in these cases. These are the example of the type A and type B tumors which are more medially and laterally located. The prognosis is different. Type A tumor has the worst prognosis as compared to the group B tumor. Now grading like the other glial tumor is controversial. Some of the features taken into consideration is morphology. For example, in subependymoma, mixopapillary ependymoma, and the other features are the cellularity, mitosis, necrosis presence is controversial, but necrosis which is palisading and associated with the endothelial proliferation indicates high grade ependymoma. These are some of the examples of the ependymoma. The morphologically one gets a lot of these ependymal rosette, sometimes the pseudo rosette which are around the blood vessels, and the presence of these rosette are very characteristic of ependymoma. The another category of tumor is the choroid plexus tumor. There is one example of choroid plexus carcinoma, just to remember. They occur in very young age children. This is one of the carcinoma. Usually carcinoma occurs in the older age, but this is one of those carcinomas which occur in children, usually in the first decade of life. The choroid plexus papilloma are benign, they are grade 1, and if the mitosis is more but not fitting in the category of carcinoma, they are called as the atypical choroid plexus papillomas. Their prognosis is worse as compared to the grade 1 tumors. There is one category of mixed tumor, neuronal and mixed neuronal glial tumors, and large number of tumors are included in this category. One I mentioned earlier with the pilocytic ependymoma, pilocytic glioma astrocytoma was the ganglioglioma. There may be dyseminoplastic neuroepithelial tumor, central neurocytoma, extraventricular neurocytomas, and so on. Now one category just to remember is the dyseminoplastic neuroepithelial tumor, DNET. These are the tumors which occurs in younger age. They are low grade. They are associated with the intractable epilepsy. They have very characteristic radiological finding. For example, this is a contrast enhancing lesion which is triangular in shape. There is history of epilepsy in this child, and morphologically in the histology they have a characteristic morphology. They are multinodular, which are usually in the cortex. This is the microcystic change. These in between there are some floating neurons, and do the surgery, it's very rewarding. These tumors are treatable. Central neurocytoma which occur in the younger adult, they are in the lateral ventricle near the foramen of Monro, may extend to the third ventricle, and very characteristic morphology which resemble the oligodendroglioma. They also show the perinuclear halo, but in between there are some fibrillary areas, and these tumors are immunopositive for NEUN, which is a neuronal marker. So they differ from the oligodendroglioma. They don't show 1p19q co-deletion. Now in the pineal region, there may be pineocytomas or pineoblastomas. Pineocytomas are grade 1 which occur in the adults. Pineoblastoma are grade 4 which occur in the younger age. The morphology is different. They show pineocytoma shows a lot of these pineocytomatous rosette, these fibrillary material surrounded by these cells, whereas the pineoblastoma are the solid tumor, very cellular, a lot of mitosis, and in between, which don't fit any of these category, are the final parenchymal tumor of intermediate differentiation, which may be grade 2 or which may be grade 3. Now, in the category of embryonal tumor, there are a lot of modification in the 2016 classification. The most common are the medulloblastomas. All of these embryonal tumor are grade 4. The second most common is the atypical teratoid or rhabdoid tumor. Then there is an embryonal tumor with multilayer rosette, C19 MC alteration, medulloepithelioma, CNS neuroblastoma, CNS ganglioneuroblastoma, and CNS embryonal tumor of NOS, which don't fit any of these categories. Now, medulloblastomas are most common. They are grade 4. They occur in children in the posterior fossa, and the prognosis is bad. In the latest classification, there are two ways of classification. One is the histologically defined medulloblastoma, other is genetically defined medulloblastoma. Now, the histologically defined medulloblastoma, they are medulloblastoma which are classical morphology, desmoplastic or nodal medulloblastoma which with the extensive nodularity, and large cell medulloblastoma or the anaplastic medulloblastoma. There is overlap in the morphology of these two tumors, large cell anaplastic medulloblastoma, so they are grouped together. And one of the categories is medulloblastoma NOS. This is one example of classical medulloblastoma. A lot of these small cells with carrot-shaped nuclei. There are some homocyte rosettes. These cells are immunopositive for synaptophysin, chromogranin, and they are centrally located. These are some of the examples of the other category. This medulloblastoma with extensive nodularity, which are very characteristic radiology, grape-like appearance, multiple nodules, and morphology is also very characteristic. These small nodule with a lot of fibrillary material, and this is the higher magnification showing the single cell, just like Indian file appearance. As compared to desmoplastic nodular medulloblastoma, these tumors are not reticulin rich, whereas the desmoplastic, if you see these nodules, they are surrounded by these reticulin rich areas. These are the large cell or the anaplastic medulloblastomas. Now, in the genetically defined group, this is also important because treatment, while some of the medulloblastoma which are genetically defined, morphologically they may look very aggressive, but behavior may not be that bad. So, that is the importance of this genetically defined medulloblastoma. And secondly, how much treatment chemotherapy to we give these tumors. So, there are the medulloblastoma which WNT activated medulloblastoma. Then the second group is the SH activated medulloblastoma, and the group 3 and group 4 medulloblastoma. Now, the importance of this classification is that a lot of trials are going on for the targeted therapy of these medulloblastomas. So, it is very important to find out from which category this medulloblastoma belongs, so that for tomorrow this targeted therapy can be given to these tumors. All these categories, there are some markers are defined for them for the diagnosis. Some of them can be done by immunohistochemistry, and this is one of study from our own department where we have proposed but combination should be done for the diagnosis of these different molecularly defined medulloblastoma. One can do the fish. The last category is the CNS peanut. This is a controversial entity. Some of these tumors which are not classified in any other categories, they are placed in the category of PNAT, but they are by exclusion. Then the embryonal tumor with multilayer rosette, they are the peanut, but they show a very characteristic alteration, C19 MC alteration, and they have very characteristic morphology. Now, coming to the malignant lymphomas, lymphomas comprises about less than 2% of all brain tumor. As I mentioned, there is no lymphatic drainage or no lymphoid tissue in the brain, but somehow because of some other predisposing conditions, there may be some lymphoid cell which migrate to the brain and give rise to the lymphoma. Most common lymphoma in the brain are B cell lymphomas, and many times they occur in the immunocompromised people, maybe HIV, AIDS, maybe some renal transplant or some other organ transplant, and they are associated with the EBV infection. These are some of the very classical appearance of the primary lymphomas of the brain. This is the blood vessels which is surrounded by these atypical lymphoid cells, and the lymphoids are also infiltrating into the vessel wall. and this can be demonstrated by reticulin stain, and these cells are immunopositive for CD20, may show some positivity for the EBV by LMP or by SHISH method. Just to mention here that the lymphomas which are associated with the Epstein-Barr virus in the Western literature are not very common in Indian population. Now, any germ cell tumor can occur in the brain. They are known as the germinomas. They may be yolk sac tumor, they may be embryonal carcinoma, choriocarcinoma, or maybe mixed germ cell tumor. Most of the germ cell tumor are in children or in younger people. They are midline, mostly supracellular or cellular location and pineal location. Rarely can occur at other sites. Now, the spread of the brain tumor, that may be local infiltration, or it may be, they may go to the CSF, they may spread along the ependymal lining, or maybe along the meninges. As compared to the other organs, the metastasis from the intracranial tumor to outside is extremely uncommon. It is very, very rare. It only occurs when there is large surgical defect in the skull and the lymphatic drainage may go outside, or these tumor may find access to the lymphatic drainage and they may spread to the other side. Very, very rarely. This is one example of the oligodendrogliomas which spread to the bones outside. Otherwise, spread of the brain tumor outside is very rare. The metastases are common in the brain, and any metastasis can go to the brain, but there is a general dictum that in the posterior fossa, most of the time the metastasis is from the pelvic cavity, and in the supratentorial region it is from the outside the pelvic cavity. Sometimes these metastases can appear like a hemorrhagic tumor, and some of the examples are the choriocarcinoma, renal cell carcinoma, or the melanomas. They can present like a hemorrhage. These are some of the example of the metastatic tumors, melanomas, adenocarcinomas, these carcinoma lung. The metastasis in the brain may be the first manifestation of the metastasis of lung carcinoma. There are other, this list shows the large number of other conditions, some cysts in the brain which can appear like a tumor or tumor-like lesions. Now, coming to the last, the molecular marker in the gliomas. Now, a lot of stress is given to the molecular markers or the biomarkers because they predict the prognosis of the tumor and the response to treatment. And this molecular marker can be tested by any method, by FISH, by CIS, or by RT-PCR, or by sequencing. Now, what WHO has proposed this time, the histological diagnosis should be a layered diagnosis. The first is the morphological diagnosis, the histopathological diagnosis, then the grade of the tumor, then the molecular studies, and the final diagnosis should be integrated diagnosis to give a better idea to the treating surgeon or the treating oncologist what treatment to be given these tumor. Now, a lot of stress has been given to these markers because sometimes these markers predict better outcome than our grade of the tumor. And just like the breast carcinoma, based on these outcomes, prognosis of the tumor, the focus has been shifted to the triple negative to triple positive tumors, because triple positive tumor for IDH, for ATRX, for 1p19q co-deletion, they have better prognosis as compared to the triple negative tumors. Thank you.